Well, thank you for the opportunity to present the results of a recently completed systematic review and meta-analysis, which we conducted to evaluate the effect of exercise intervention on the prevention and treatment of lymphedema. My name's Sandi Hayes. I'm based at Griffith University in Brisbane, Queensland, and am co-lead of the IHOP research group. I'd like to begin by acknowledging the traditional custodians of the land on which I'm giving this presentation, the Turrbal people, and recognise their continuing connection to land, water and community. I pay respect to elders past, present and emerging. So let's begin. Since the early to mid-2000s, there's been an exponential rise in studies evaluating the link between physical activity, including exercise, and cancer-related outcomes. This original research, which includes both observational studies as well as clinical trials, has been included and summarised in over 140 systematic reviews and meta-analyses to date. The body of contributing research has involved a range of cancers, including beyond our common cancers, breast, prostate and colorectal cancer. It's looked at the relationship between physical activity and outcomes pre, during and post-cancer, and has evaluated safety, feasibility and the effect on a range of objectively measured and self-reported outcomes, including lymphedema. Right up until about the last 5-ish years, benefits derived through exercise was promoted as being all about function, morbidity and mortality. However, we've seen an exponential rise in research that has explored the role of physical activity pre and post-cancer on mortality outcomes. This evidence, which includes data from 136 studies, was included in a different review and meta-analysis. And as you can see by the figure on the slide, findings showed that a clear relationship between physical activity and mortality exists. Specifically, results showed that higher levels of post-diagnosis physical activity was protective against cancer-specific mortality in studies that included all cancers, as well as those for breast, colorectal and prostate cancer, with the magnitude of effect being significant. A 59% risk reduction was observed. For all-cause mortality, higher levels of post-diagnosis physical activity was also protective following 11 cancer groups, with overall risk reductions of around 60% being observed. The consistency of the findings, which have demonstrated benefit through physical activity, drove the first exercise prescription guidelines that were published in 2009 and 2010, and then more recently the update to these guidelines published in 2019. Two very different approaches were taken to derive the recommendations presented. The recent Australian exercise guidelines provide a recipe for the individual prescription of exercise that takes into account patient priorities, scientific evidence, including its strengths and weaknesses, as well as clinical practice and experience. In contrast, the American College of Sports Medicine guidelines were produced following a review of the evidence, and they provided a prescription only for those outcomes for which there was sufficient and strong evidence. It was concluded that there was enough evidence available to support specific doses of aerobic and resistance exercise for anxiety, depression, fatigue, physical function, and health-related quality of life. In specific relation to lymphedema, it was concluded that a supervised progressive resistance exercise was safe for those at risk with breast cancer-related lymphedema, but that there was insufficient evidence to draw safety conclusions for unsupervised exercise, aerobic exercise, or for those at risk of or with other types of cancer-related lymphedema. However, since the late 1990s, there's also been an exponential rise in the number of studies evaluating the role of exercise, including beyond resistance-based exercise alone, in both the prevention and treatment of lymphedema. There have also been systematic reviews published on this topic, but these have restricted inclusion of studies to those with interventions involving resistance exercise, or they had a focus on breast cancer-related lymphedema. Therefore, we thought there was a need for a more inclusive systematic review and meta-analysis of the lymphedema and exercise literature to better understand potential effects rather than just safety of exercise in the prevention and treatment of cancer-related lymphedema. We were also interested in evaluating the effect of exercise on other health outcomes that matter to those with cancer-related lymphedema, including quality of life, fatigue, upper and lower body strength, aerobic fitness, body weight, body mass, and body fat. Finally, it was also an objective to evaluate whether prevention or treatment effect differed according to exercise mode, length of exercise intervention, degree of exercise supervision, lymphedema type, and extent of lymph node removal, although that was only relevant for the prevention arm. The protocol for the search, including the search strategy and inclusion criteria, which was based on the PICO framework, have all been registered on Prospero, and I won't go into detail here about that. The quality of all the included studies was assessed using a specific quality scale, and the level of evidence was graded. Suffice to say here, following removal of duplicates, title and abstract screening, and then full text review, 12 studies contributed to the prevention aim and 36 studies contributed to the treatment aim of this review. For the prevention arm of the review, all except one study involved women at risk of breast cancer-related lymphedema. The majority of studies had small sample size, that is less than 60, and 50% involved testing resistance-based exercise either alone or in combination with aerobic exercise. For the treatment aim, 10 studies evaluated the immediate effects of a one-off session, while 26 evaluated interventions with durations longer than 8 weeks. Of the intervention studies, again, the majority involved small sample sizes and over 50% evaluated resistance exercise. Throughout the 12 presentation studies, a range of interventions have been tested involving aerobic exercise only, resistance exercise only, mixed mode exercise, which includes both aerobic and resistance exercise, as well as other types of exercise such as football. There was a large degree of heterogeneity in the FIT principles evaluated across these studies, that is the frequency, intensity, time and type of the exercise that made up the intervention, with session duration ranging from 15 to 60 minutes, 2 to 4 times per week of typically moderate intensity and over 8 weeks to 18 months. Okay, so this slide shows the first of several forest plots that I'm going to show you, and it compares the risk of developing lymphedema between those in the exercise group versus those in the control group. When the square is to the left of the vertical line, that means that risk is lower for those in the exercise group. The overall risk, taking into account data from all 12 studies, is shown by the diamond at the bottom of the figure. You can see that for the overall result, relative risk for those in the exercise group is reduced, although the right edge of the diamond spans the vertical line, which means that these results are not supported statistically. All the squares above the diamond show our subgroup results, and they all favour exercise. That is, irrespective of whether the intervention was aerobic-based, resistance-based, mixed mode or other type, irrespective of intervention duration, irrespective of whether the exercise was supervised or unsupervised, and irrespective of the extent of lymph node removal, those in the exercise group had reduced risk of developing lymphedema. You'll note we did actually look at whether type of lymphedema, that is upper versus lower lymphedema, influenced the findings, but only one study involved lower limb lymphedema, which means this subgroup analysis was not possible. The only results that were supported statistically was for those who had 5 or more lymph nodes removed, suggesting that those at the greatest risk of developing lymphedema, that is those with more lymph node dissection, have the greatest risk reduction through participation in exercise. Let's move to the treatment setting. 10 studies have evaluated lymphedema status immediately pre and post an acute bout, that is a one-off bout of exercise. All sessions were supervised, either aerobic-based, resistance-based or other exercise mode, with sample sizes ranging from 5 to above 60, including low, moderate and high intensity. This forest plot shows the change in lymphedema and lymphedema-associated symptoms between pre and immediately post the exercise session, and then pre and 24 hours post the exercise session. The middle of the large diamonds, which take into account all contributing data, is to the left of the vertical line, which suggests a tendency towards a reduction in lymphedema, but the degree of change was neither statistically nor clinically relevant. There was also no important change in lymphedema-associated symptoms, either positive or negative, detected after a single bout of exercise. So now we're about to talk or to take a look at the studies that evaluated the effect of an exercise intervention on lymphedema. Again, a large range of exercise modes have been assessed, including interventions that do not include resistance exercise. Of the 26 studies included, 40% of them have been unsupervised, and intensity has ranged from low to high. This forest plot shows the results from the meta-analysis of change in lymphedema following participation in an exercise intervention, separated by exercise mode, degree of supervision, and lymphedema type. You can see by the diamond at the bottom of the figure that lymphedema is reduced for those in the exercise group. Again, these results are not supported statistically, as the right side of the diamond ever so slightly spans the vertical line. But what we can see is that reductions in lymphedema are observed irrespective of exercise mode, irrespective of degree of supervision, and irrespective of lymphedema type, that is upper versus lower lymphedema. There are two exceptions to this within this subgroup analysis. One is aerobic exercise. However, you'll see that for this subgroup, confidence intervals are wide, with data from only 51 participants contributing. As you increase the number of studies that contribute within any given subgroup, the confidence intervals tighten and you start to have more confidence in where the standardised mean difference sits. That's the SMD. The second exception was the mostly supervised group. And again, I think this is about the amount of contributing data influencing the precision over their SMD, rather than it being a reflection that mostly supervised interventions cause an increase in lymphedema. Now, it's only to the right of the line. It's not a clinically relevant shift to the right of the line. But the point is, when we're looking at degree of supervision and has it got a potential to influence the effect of exercise on lymphedema, we're looking for not just the standardised mean difference and a clinically relevant standardised mean difference, but we're looking at trends in the data. So, for example, if supervision was particularly important, you would tend to see a trend where we've got favouring of exercise for the supervised and mostly supervised towards an unfavouring for the mostly unsupervised or the fully unsupervised, and you don't see that. Okay, so this forest plot shows the results from the meta-analysis comparing lymphedema status of those in the exercise group compared with the control group at post-intervention, with subgroup analysis again for exercise mode, length of intervention, and degree of supervision. You can see by the diamond at the bottom of the figure that lymphedema is reduced, for those in the exercise group compared with those in the control group. Again, these results are not supported statistically, as the right side of the diamond ever so slightly spans the vertical line. But what we can see is that reductions in lymphedema are observed for all the subgroup analyses, with the exception of those in a mostly unsupervised setting. The standardised mean difference for this subgroup analysis, though, was 0.01 with very wide confidence intervals. So apart from that, all these squares are to the left of the line, favouring a reduction in the outcome. This forest plot shows the benefits accrued through exercise intervention on other health outcomes that matter to those with lymphedema, including lymphedema-related symptoms such as pain, heaviness, tightness, and quality of life. Then we've got other outcomes: quality of life, upper body function, muscular strength, and fatigue. These are important findings because they demonstrate that even if exercise didn't lead to a reduction in lymphedema, it has other additional clinically relevant health benefits that will influence the lives of those with cancer-related lymphedema. There was no effect through exercise intervention on body weight, body mass index, or body fat. Sorry, there we go. So down here, body weight, body mass index, or body fat. But this is actually in line with what we see for these outcomes in exercise oncology studies more broadly, beyond people with cancer-related lymphedema. That is, exercise tends not to have an effect on body weight or body fat. What it does influence, though, is lean tissue, and this outcome was not assessed in cancer-related and exercise trials, so unfortunately we can't see its influence on that outcome in this review. So there's no doubt that we still have much to learn about the role of exercise in the prevention and treatment of lymphedema. We need to explore the impact of lymphedema, the impact of exercise beyond women at risk of or with breast cancer-related lymphedema. So it is still true that the vast majority of our work has been focused or involved women at risk of or with breast cancer or lymphedema, of breast cancer-related lymphedema, and we need to move beyond that. We also need to evaluate the impact of exercise on early stage versus late stage, more chronic lymphedema. And I'm pointing this out because for those studies that involve people with lymphedema, it typically involves people who have had lymphedema for a number of years. So it's definitely persistent chronic lymphedema. And the power of exercise might be greater in the early stages of lymphedema that is characterised by increases in extracellular fluid. We also need to investigate interventions that are designed for integration in the real world. And I'm highlighting this because there is a perception that those at risk or with lymphedema need to have supervised exercise. But actually, these studies are telling us that as long as there are parameters in place, unsupervised exercise can be just as beneficial as supervised exercise. While I didn't show you the results for this subgroup analysis, we did also look at the influence of our findings of whether things like method of assessment, the way in which lymphedema was assessed within these studies, and the study quality, whether those two factors influenced the results that we saw, and they did not. And this really provides confidence that exercise, it provides confidence in our findings, with the overall findings suggesting that exercise is not just safe for those at risk of or with lymphedema, but instead that actually participation in exercise may in fact prevent lymphedema, particularly for those with more extensive lymph node dissection. Participation in exercise may reduce lymphedema for those with lymphedema and will lead to improvements in other important health outcomes. And that those with or at risk of lymphedema do not need to be restricted to supervised resistance-based exercise. These findings suggest that all modes produce similar benefit, including when unsupervised, and suggest that physical activity and exercise guidelines that are promoted to the wider cancer population are likely applicable to those at risk or with cancer-related lymphedema. Now, there are some caveats around this, and I hinted to this on the previous slide, and these caveats are that all these studies would have encouraged progressive exercise guided by symptom response. But again, this is in line with exercise recommendations promoted to those with cancer more broadly. So to finish, I would very much like to acknowledge the work of my collaborators who are listed on this slide. The paper that supports this presentation is currently under review, so hopefully it will be accepted for publication in the next month or so, and you'll be able to go take a look at it for a much more detailed account of what we did and the findings that support the conclusions. If you'd like more information, though, you can contact me via Griffith University or via any of the platforms listed on the slide. And maybe next time I'll be able to give a presentation in person. Thank you.
Hello, I'm Naomi Dolgoy, and this is Mona Al-Onazi, and today we'll be presenting to you on debunking the myths around resistance and strength training exercise in cancer-related lymphedema. We have no conflicts to report. As this is a virtual conference, we also wish to pause to honor the land we use wherever that may be, and those who came before us, whomever they may be. In today's presentation, we will discuss resistance exercise and cancer-related lymphedema. We will, first, debunk misinformation. Then we will review current literature. We will then touch on emergent research. And finally, we will demonstrate resistance exercises for upper and lower body lymphedema. Strength or resistance training involves making the muscles work against an active external force. This force could be equipment, such as resistance bands, weights, or the timing, like repetition or length of activity. Essentially, any heavy work that activates muscle contractions. Now, while the positive outcomes for physical exercise after cancer are well established, the benefits of resistance activity for cancer-related lymphedema are less accepted. So let's further explore therapeutic resistance as one targeted approach in managing cancer-related lymphedema. Before 2010, the accepted practice for post-surgical interventions for breast cancer included lifting no more than 5 to 10 pounds on the affected arm after treatment. For context, pulling open a fridge door full of food falls at the high end of this spectrum. For the lower body, activities that involved force or pounding movements were to be avoided. So this would include weights, even when the upper body was holding the weights, because this would put more strain on the legs. And there were no specific end dates for when avoiding activities should be completed. It was discretionary when these restrictions would be lifted. So some individuals at risk for developing cancer-related lymphedema, or those who had developed it, simply stopped using their affected limbs. And some individuals just stopped engaging in physical activity, so they became deconditioned and experienced health-related issues, including weight gain and muscle loss. Now, there is no substantial evidence that lack of activity correlates with reduced risk of developing or managing lymphedema. Despite the research evidence, there are not yet protocols for resistance exercise for lymphedema.
So why to exercise? There is strong evidence support the importance and benefits of exercise for cancer treatment and health-related outcomes. Here are some of many exercise benefits that speaks to the importance of exercise as medicine. And in order to improve these outcomes, survivors need to be engaged in moderate intensity aerobic and/or resistance exercise 3 times a week. So, with all the evidence supporting the value of exercise, what is the problem? Looking closely at the issues among survivors who are with or at risk of lymphedema, majority of them reported at least one of these physical symptoms after cancer treatment, which is associated with impaired function. Majority are overweight or obese at the time of diagnosis, and only 30% of cancer survivors met physical activity guidelines, and the level of activities dropped with cancer treatment. And some individuals try to avoid certain activities due to fear of triggering lymphedema, which could again impact the function. Subsequently, all of these issues could lead to development or progression of lymphedema.
Now, in looking at the risk of engaging in physical activity, or any activity at all, there is always a risk of injury. The question is, how great is that risk? Is there a higher risk of injuring or impairing the affected or at-risk limb in activities versus in avoiding activities? So functionally, limited or reduced activity can result in further physical issues, deconditioning, and lymphedema complications. And reduced activity engagement can also lead to isolation and loss of independence and other health-related complications. For movement and physical activity, the research points to high benefits for engaging in safe, lymphedema-friendly resistance and strength training exercises, and very low risk of negative impacts. The research also points to high risk of impairment for those who have developed or are at risk of developing lymphedema when they avoid physical activity. And there are effective ways to change activities or how the affected extremity is used so that inactivity or problematic movement patterns, such as guarding a limb, don't become routine. So let's talk more about effective exercise.
Moving to lymphedema management, this figure shows the typical 2 phases of complete decongestive therapy, which is the standard care in lymphedema management and involve compression therapy, exercise, self-care or skin care with or without manual lymphatic drainage. The blue phase is the intensive phase and the orange one is the maintenance phase. And although exercise is one of the main components of these 2 phases, as you see here, most of the treatment approaches rely mainly on manual lymphatic drainage and or compression therapy, which are considered as passive forces and ignore the active forces of the body, such as skeletal muscle pumping and respiratory motion. So let's talk more about that by taking a closer look at the effect of exercise on the lymphatic system. As you see in this image, the lymphatic vessels are everywhere in our body to drain the lymph fluid. The lymphatic system rely mainly on 2 pumping mechanisms, which is caused by the lymphangian contraction, which, as you see in this image, heart-like chambers that intrinsically propel lymph in a rate of 6 to 10 per minute under normal circumstances. Extrinsic pumping, result of pressure change or movement outside of the lymphatic vessels due to, for example, skeletal muscle contraction and respiration. So with movement or exercise, we stimulate the skeletal muscle pump, and that will increase the lymph flow rate and lymphangian contraction by more than 10 times, and that depends on the type of exercise. And breathing has similar effect with the change in tissue pressure, and using deep diaphragmatic breathing can also help propel the lymph centrally toward the chest. Now let's take deep breath by doing deep diaphragmatic breathing together. I want you to sit up straight, keep your shoulder down, and put your hand on your tummy to feel the movement. Now close your eyes, and as you inhale, imagine your tummy filling up with air like a balloon. Hold for a few seconds, and as you exhale, imagine your balloon tummy deflating as you squeeze in to expel the air out. You can repeat for a few times and then relax. So what happened when we combine these 2 extrinsic pumping mechanisms? A study found that simple 10 minutes exercise that combined gentle arm exercise and deep diaphragmatic breathing did demonstrate a significant decrease in lymphedema volume and symptoms of heaviness. You can try that now by taking deep breath as you open your arms and hands away from your body. And as you exhale, move your hands towards your chest while making a fist. You can repeat for a couple of times. And for lower limbs, you can follow the same pattern of the movement. So exercise can help lymphatic system, and introducing more targeted exercise can not only improve the health-related outcomes, but also has the potential to improve lymphedema outcomes. So where are we in terms of research evidence? As we mentioned before, strong evidence support the safety of general resistance exercise for those with or at risk of lymphedema. Using compression garment during exercise is recommended. And in terms of adding therapeutic exercise, few studies included therapeutic components such as decongestive sequence to enhance the lymphatic flow. The findings of these studies showed potential beneficial effect on lymphedema. So putting all of these pieces together, the questions are, what's the effect of general exercise versus therapeutic exercise on lymphedema? And what is the optimal prescription? Also, do patients benefit from wearing compression garment during exercise? So to address these gaps, we are conducting a randomized controlled trial with a focus on movement pattern and breathing, using resistance exercise that follows decongestive exercise sequence in addition to compression use. And by combining these three pieces together in DREAM study, we are looking at the impact of this program on total arm volume, arm tissue composition, including muscle mass, fat, and fluid, as well as the effect of program on function, strength, and quality of life. And we aim to develop step-by-step protocol for lymphedema exercise.
So when it comes to strength training and resistance exercises, where should we start with a lymphedema exercise program? So the rule is to start with a slower, progressive program. Start low, progress slow. The American College of Sports Medicine recommends 2 to 3 times a week for exercise. And the FIT principles come into play. So this refers to frequency, intensity, time, and type. So where the speed is, the level of activity, the amount of duration of the activity, and what kinds of exercises are being completed. And finally, the opportunity to modify or tailor an exercise program to meet an individual's needs. And so it's important to consult with healthcare providers and to ensure that the program fits your body.
So where to start? We can start from the basics with decongestive lymphedema exercise. And the principles of these exercises involve incorporating deep diaphragmatic breathing and using active non-resistive movement that follows specific sequence as you see in this image from proximal to distal and then reversing the order with the use of compression garment or compression bandaging. And the aim is to enhance muscle pump effect on lymphatic and venous system. This can be a good starting point for someone not involved in any exercise activity. You can start with 10 repetitions, 1 to 2 times per day. And then progress, with gradually increasing the intensity by increasing the number of repetitions and or sets. And once you build the stronger muscles, then you can add more resistance. And you can do that by using resistance band, dumbbells, weight machines, or even without formal equipment. Anything with some structures or elasticity from old yoga bands or belts or towels can be used. We will give you more guiding examples at the end of this presentation. And the point is that resistance exercise is totally accessible and you can start now from home.
So now we'll talk about examples of exercises for strength and resistance training for upper limb lymphedema. Normally, before we start the exercise program, we would begin with a deep diaphragmatic breathing warm-up as we discussed in the previous slides. As we go through these examples of resistance and strength training exercises for lymphedema, we'll show examples of each exercise, and you'll also notice that in the top corner of each slide there is an image of the lymphatic system that will reflect which muscle and lymphatic area are being activated by each resistance exercise. As we go through the exercises, the idea is to use slow and deep breathing, approximately 2 seconds for inhalation and 4 seconds for exhalation. The idea is to breathe as the activity is being completed using exertion with the exhalation. We always begin with the unaffected limb and then continue to the affected limb on unilateral exercises. You'll notice with the upper limb lymphedema exercises, they'll move from the upper shoulders and larger muscle groups down towards the hand, similar to the pattern of decongestive therapy, and then move from the hand back up towards the shoulder. Let's get started. Shoulder shrug. Moving slowly, we would inhale on exertion as we move the shoulders up towards the ears, and then exhale as we release the shoulders down towards the lower body. Shoulder retraction or chest press. So in these exercises, using the band, we would complete elbow flexion and extension, exhaling as the band slowly releases and inhaling with the tension. Seated row. So in this exercise, we would use the feet to anchor the resistance band, moving the elbows back and squeezing the shoulder blades with slow and steady exhalation as the tension is released. Shoulder press. In this exercise, we would raise and lower the shoulders, making sure that we moved with the range of motion of our bodies without any pain. The relaxation exhalation would come on releasing the tension in the band. Biceps curl. In this exercise, we would move the band down the arm as we straighten the arm and then add tension as we bend the elbow. We would exhale as we release the tension, inhale as the tension grows. Triceps pullback. So in this exercise, there are many different ways to hold the band depending on an individual's mobility and comfort. We would want to make sure that the movement was done slowly in alignment with the breathing and within the range of motion that worked for each individual without creating any pain or pressure. As the tricep is activated, there's tension in the band and then released with the bend of the elbow. Wrist extension. So moving to the extremity or to the hand, we would use the support of a table or a pillow or no supports depending on the strength and what our body needs. This involves slow, methodical movement up and down of the wrist to add tension to the band and pump the muscles. Wrist flexion. Similar to the previous exercise, but positioning the hand in the opposite way. Again, slow and methodical movement aligned with breathing, where we activate the wrist to work the lymphatic system. Ball squeezing. So moving into the hand, we want to activate the hand with pumping movements, slow and methodical, aligned with the breath. Resistance bands, squeeze balls, face cloths could be used, or even just imagining that the air is thick in making a fist and releasing it. It's basically a slow and methodical pump and squeeze of the hand. Once we've moved through the diaphragmatic breathing, and then from the shoulders all the way down to the hands, we would reverse the order and complete movements back towards the shoulder in the opposite way. Again, slow, methodical movement aligned with the breath.
Now we will move to lower limbs with some exercise examples. And similar to upper limb exercise sequence, we will start with deep diaphragmatic breathing and then big muscle groups in the hip going down to the foot, using slow, controlled movement and deep breathing. And again, the rule of thumb here is 2 seconds breathe in and 4 seconds breathe out with exertion. And always start with the unaffected limb. So let's start exercising. Squat. For this exercise, you can use body weight only or add exercise ball behind your back or use resistance band to increase the intensity. Make sure your back flat and chest high and engage your abdominal muscles. So now take deep breath and as you exhale, slowly sit back into a squat, going as low as you can without allowing your knees to go further than your ankle. Hip abduction. Tie the resistance band around your ankles. Now take deep breath and as you exhale, raise your straight leg to the side without turning your foot out. Then slowly return to the starting position as you inhale. Hip flexion. For this exercise, you can use chair to balance yourself. Now tie one end of the band around your thigh and step on the other end. Take deep breath and as you exhale, bend your hip as you raise your knee up towards your chest. Slowly return to the starting position as you inhale. Knee extension. From sitting, tie one end of the band around your ankle and the other end around the leg of the chair. Now take deep breath, and as you exhale, extend your knee slowly and then return slowly to the starting position as you inhale. Knee flexion or leg curl. From sitting or standing, tie one end of the band around your ankle and step on the other end, or tie it to a table leg. Now take deep breath, and as you exhale, bend your knee, keeping your back straight, and then slowly return to the starting position as you inhale. Ankle plantar flexion. You can either hold the elastic band around your feet or tie one end around your foot and hold the other end in your hands. Now take deep breath, and as you exhale, push your forefoot down against the band and then slowly return to the starting position as you inhale. Now, as we improve the lymphatic flow with these exercises, we will reverse the order, doing the same exercises starting from the foot up towards the hip and deep diaphragmatic breathing to increase the lymphatic return away from the affected area.
So sometimes a barrier to resistance and strength training exercise can be the equipment. So in this slide, we wanted to demonstrate that some of the more professional or gym equipment can be replaced with at-home options. So everything from a ketchup bottle to a towel to old yoga pants can become a piece of resistance equipment to help achieve goals of engaging in physical activity. Finally, in debunking the myths around resistance exercise risks and best practice in cancer-related lymphedema physical activity, there is strong evidence supporting the benefits of resistance exercise. There is ongoing research to develop resistance exercise program protocols for cancer-related lymphedema to help embed resistance exercise into clinical practice. But most importantly, there is always a way, sometimes adapted and modified, but there is always a way to engage in physical exercise.
Thank you. Feel free to contact us. And if you're interested to know more about Dream Study, please visit this webpage.